مؤنس أكاديمي. بسم الله الرحمن الرحيم. أقدم هذا العمل خالص لوجه الله الكريم، آمل أن يكون عونا لشباب الأطباء ليقدموا خدمة صحية عالية المستوى ترقى بالطبيب العربي وتقدم للمجتمع خدمة متميزة بأمانة وإخلاص. From bedside to best practice. Here we have a 64 years old diabetic woman presented with persistent diarrhea. His past history of kidney transplant last year for end-stage renal disease. She have a multiple myeloma. Her diarrhea started after her kidney transplant. Stool culture are negative and she has both day and night stool with minimum 10 per day, and she has admitted in the past months for severe ileitis, severe ileus, and was taking anti-diarrhea medication at this time. Colonoscopy reveals that she have a mild patch of erythema. As we see here, it's a mild patch of erythema in the rectosigmoid, cecum, and ascending. We take a biopsy from the terminal ileum from the right and left colon, which showing this foci of cryptitis, crypt distortion with focal necrosis, and apoptotic bodies. So this patient has a chronic diarrhea, making liver transplant, taking a medication because of fixation of after transplant. The diarrhea started after transplant. Colonoscopy shows multiple patch scattered rectosigmoid, cecum ascending, and biopsy saying that high eosinophils scattered with crypt distortion and cryptitis and apoptotic bodies. So, what is the most likely etiology for this patient? I would like to remember you the pathology. Cryptitis, crypt distortion, high eosinophils with apoptotic bodies. So, is it Crohn's disease? Is it cytomegalovirus colitis? Is it magnesium because the patient is receiving magnesium? Or due to mucophenolate? Or due to tacrolimus? To answer this question, you have to go back and know what is the etiology for this. So, macrophenolate, based on the histology, endoscopy, and pathological finding, this patient has mucophenolate induced diarrhea and colitis. Why? Because first she is rapidly improved when stopped mucophenolate. When scheduled the treatment, she taking magnesium and tacrolimus, both can causing diarrhea, but not colitis. Diarrhea without colitis. Cytomegalovirus, it's okay. Yes, cytomegalovirus can induce diarrhea, but on the histopathology, they didn't say that there is an intracytoplasmic or intranuclear inclusion bodies, which is a characteristic for cytomegalovirus. What is the intranuclear inclusion bodies? In intranuclear inclusion bodies, it is a strong suggestion of viral infection or neurodegenerative disease, supporting by the caudal A inclusion bodies في السيتوميجالوفيروس، ولكن في الهيربس سيمبلكس فيروس، ولكن في السيتوميجالوفيروس ليها حاجة very characteristic اللي هو owl eye، زي عينين البومة. ليه؟ لأن الفيروس بيخش جوه النيوكليس وبيعمل هالة من حواليها، فبتبقى عاملة زي الأول آي. So This is what's called intranuclear inclusion bodies, which owl eye, which is characteristic for cytomegalovirus, and intracytoplasmic also, because the virus is included in the cytoplasm. And in immunohistochemistry, cytomegalo is negative. Prominent eosinophil infiltration are atypical for cytomegalovirus infection. So there is no intracytoplasmic, no intranuclear inclusion bodies. Cytomegalovirus immunohistochemistry is saying negative, and cytomegalovirus infection never do eosinophilic infiltration happened. So the medication induced colitis, showing that characteristic numerous eosinophils with apoptotic damage or apoptotic bodies. So if you found high eosinophils with apoptotic damage, it is a characteristic for drug-induced colitis. If you found intranuclear inclusion bodies, so it is virus, either herpes simplex or cytomegalovirus. Herpes simplex virus diagnosed by cow dry A inclusion bodies. لأن cow dry في A و B، دي cow dry A inclusion bodies. ولكن cytomegalovirus owl eye characteristic. المغنيسيوم والtacrolimus does not cause colitis. So the only is mycophenolate. Here a next case of 75 years old woman, sick skilled nursing facility with multiple medical problem, including with chronic idiopathic constipation, persistent with 2 weeks of a worsening constipation and bloating. He typically has a bowel movement every 4 to 5 days, and by help of polyethylene glycerol 17 grams twice daily. Nowadays, her bowel movement is once weekly and helped by enema. Presented to the ER with worsened abdominal pain and distension. Her pain is 4/10, located in the lower left quadrant without radiation. CT abdomen and pelvis show mild diffuse dilatation of the colon with one segment in the sigmoid dilated to 7 centimeters without significant fecal impaction, but with diffuse stool through all over the colon. Admitted laboratory various, all are unremarkable except white blood cells is 16,000. A patient admitted, all narcotic are healed, her electrolyte optimization, and rectal tube is placed for decompression. Over the course of 2 days, repeated colonoscopy, repeated CT shows that the sigmoid colon become more dilated to 9 centimeters. So surgery and gastroenterology consultation, obtaining a colonoscopy and for decompression and further diagnosis. And in the colonoscopy, as we see this picture, it's typical for pseudomembrane. So what is the next step management for this patient? Are you refer the patient for colectomy, or you continue on conservative treatment, or you start Cipro-Metro, or you start Vanco-Metro? To answer this question, you have to know what's the diagnosis. If I see this picture while I doing colonoscopy, it's picture of C. diff colitis. Typical C. diff colitis. Why the risk factor? The risk factor is elderly patient. and living in skilled nursing facility. All these risk factor for developing C. diff colitis. It's important to remember that the most common presentation of C. diff is diarrhea, but you have to take care. It's also can present it with the constipation like this patient. So not all the patient with C. diff coming with diarrhea. It's some people coming with constipation. Colectomy is very premature because this is a only mild elevation for the white blood cells. Conservative measure, no, it's not appropriate because the colonoscopy show evidence of progressive and require intervention. Starting Cipro Metro is incorrect because Metro alone have some activity against C. diff, and the patient have white blood cells 15,000. So it is a severe, complicated case. All guidelines recommend oral vancomycin and intravenous metronidazole. So the answer will be intravenous metronidazole with vancomycin. Thank you. إذا كان المحتوى شايفينه إن هو كويس فيا ريت نشارك، نعمل لايك وشير، وأهلا وسهلا بأي كومنت.